Right. Welcome, everyone. I am Sarah Ramaya, Curriculum Design Strategist and Webinar Coordinator at ASRM. We have a fantastic panel and a great topic to discuss today. Before we begin, please note, this webinar was developed by the American Society for Reproductive Medicine as an educational resource and service to its members and other practicing clinicians. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional or clinical practice limitations. Please note, time at the end of the presentation we reserve for questions. Please type a question in the question and answer window. We will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks, so please watch your email for notification. I will now transfer this webinar to our moderator, Dr. James Smith.
Great, thank you, Sarah, so much. And I really would like to extend my my gratitude to both American Society of Reproductive Medicine as well as our two social interests, special interest groups that are focused on disparities and access to care. And I'm really grateful that ASRM is allowing us to talk about this really critical topic today. So by way of disclosures, I have equity interests in these three companies. And to introduce our speakers and myself, my name is Dr. James Smith. I serve as Director of Male Reproductive Health up at UCSF. And our panelists today are Denise Asafu-Adjei, who's an assistant professor of urology in Chicago at Loyola Stritch School of Medicine. And she also serves as Director of Male Reproductive Medicine. Dr. Akanksha Mehta at Emory's School of Medicine is associate professor there of urology and serves as director of male reproductive health. And Dr. Tolulope Bakare from UT Southwestern, who's assistant professor and director of male reproduction. And Dr. Jim Dupree from the University of Michigan, who's associate professor and the ambulatory care chief of urology. So essentially, our objectives for this particular session are multiple. One is to understand that infertility is disease, as we're really well aware in this audience, to detail relevant male fertility regional and national epidemiologic factors that are relevant in this area, identify factors that impact access to care, and also develop some strategies to break down these barriers. To explain some cultural, ethical factors that impact the reluctance for some people to engage in third-party reproduction, and also describe the ways in which insurance coverage facilitates access to male fertility care, and then characterize the role that advocacy can play in improving some of these barriers. So specifically, a number of the topics that our panelists are going to dive into are really diving into many of these barriers that can be lack of access to data for us to just understand the problem, geographic barriers that exist throughout the country in terms of people not being able to access reproductive services, just knowledge about what a person can do and what options exist. And then the clear high cost, both in terms of financial dollars, time cost away from work, and then socioeconomic and cultural factors that play a role. And then finally, the roles in which structural factors like government and health policy play a role here. So with that, I'd like to turn this over to our first speaker. And so I'm really looking forward to hearing all of our panelists today.
Okay. Good afternoon, everyone. Thanks so much for having me. Thanks so much for that introduction. I'm really happy to be talking about this topic today. I'm going to kick off with discussing some disparities in access to male infertility. And these are my disclosures. Some of the learning objectives for my presentation are going to include your ability to summarize regional male infertility epidemiology, identifying factors that impact access to care for male infertility services, and then finally explaining cultural and ethical factors that impact reluctance to engage in third-party reproduction. And this is just a brief outline of what we're going to be talking about. We'll start with epidemiology, followed by access to male infertility services. We'll talk a bit about ethical concerns in sperm donation and some concluding facts. So epidemiology. So infertility affects about 15% of couples worldwide. Male factor infertility exclusively accounts for about 20 to 30% of infertility cases, but contribute to about 50% of infertility cases overall. In North America, male infertility affects about 4.5 to 6% of men, and global rates of male infertility range from about 2.5 to 12%. Now, quantifying the true numbers accurately is really difficult for a variety of reasons. One, cultural and society historical trends still deem infertility as being the woman's fault. And so it really is hard to get true numbers when it comes to male factor infertility. Religious beliefs also greatly impact our ability to quantify how much this is really affecting men. Infertile males lacking or not participating in surveys also skews some of the numbers that we see in some of these national and worldwide surveys. There's also varied definitions of timeframes for infertility across studies. So that also makes really pinning down these numbers a bit challenging. And then finally, which is also part of why we're having this panel, male infertility is not viewed as a disease. So when we're thinking about how this is affecting men, people may not be necessarily coming forward because they truly may not see this as being a disease like other things are viewed. This is a great map out of a paper by Agarwal et al. That actually shows regional breakdowns of male infertility trends. This is really interesting because you can see that although it appears that the numbers may be higher in some westernized countries, so North America, you can see 50%, you also see higher numbers in European countries. It's really just thought that when, as I mentioned before, when it comes to really quantifying the numbers, are men coming forward? Are they participating in the surveys? And how are these numbers being gathered? So it is thought that we just do a better job in some westernized countries in getting these numbers, which accounts for why it appears that the infertility rates may be higher, but it just may be that we're just not capturing all the men. I wanted to talk briefly about Africa's infertility belt, and this is a stretch across Central Africa from Gabon to the United Republic of Tanzania with really high rates of male infertility. Female infertility rates are also some of the highest in the world here. However, underreporting rates in men are very high also due to cultural beliefs and just societal setup, which still targets women for fertility issues. Additionally, male infertility rates are also high in the neighboring region of the Middle East. So especially when we think about future directions, really interesting part of the world that does actually have pretty high rates of infertility that we still have to elucidate why we're seeing it in those areas and how we're quantifying it. So access to male infertility services. So as a urologist, I'm of course going to first start off with just thinking about the urological workforce. This is one of the latest graphs actually from our American Urological Association census showing the breakdown of practicing urologists by state and by density. You can see that some of the usual suspects in terms of high density like California, Texas, New York have really higher ratios of practicing urologists. But if you look at even some of the densest areas, this still just means anywhere from about 414 to about 1,600 urologists in the entire state. And so when you think about that in the context of these states that have millions and millions of people, we simply just don't have enough urologists to match the patients that we need to see. This further emphasizes a point of the disparities between urologists and the population, with on average about 4 urologists per 100,000 people in the United States. And this is also in that same census, and this really just emphasizes when we think about different areas that people seek to do fellowship in within urology, even when you look at male infertility, we still are a really small number when you look at the percentage of those who are going on for fellowship training. And then when we look at the racial diversity within the United States urological workforce, in addition to us just not having enough urologists, we still clearly also have some work to do in terms of diversifying the workforce amongst urologists, just to better reflect the patients that we see here in the United States. So male infertility awareness and education, there continues to be a global lack of education and awareness that men can suffer from infertility, driving the overall low rates of men seeking medical care for this. And there's still tons of stigmas about male infertility, masculinity, and this continues to permeate various communities, which still deem it as being a quote unquote woman's problem. Early education and awareness about fertility lags in men also compared to what a lot of women face when it comes to just being very aware of their fertility early on in puberty and just earlier on in their lives. I'm not going to delve into this too much. Dr. Dupree is going to talk about this a lot more, but insurance inequities definitely also play a part in male infertility. Donor sperm utilization. The United States actually does not track the use of donor insemination, and bring this up also to say couples that may be struggling with infertility in which male factor is a primary component. A lot of private sperm banks are actually not even required to release the ethnic origins of their donors publicly. Looking at a study by Orocho et al., donor insemination grew significantly between 2015 and 2017, with an estimated about 440,000 uses of donor sperm, but most users were white, urban, college educated, older age, and higher incomes. So when you again think about access, who is really getting the information and who is actually taking advantage of seeking out care for male factor infertility. And then finally, ending with kind of ethical concerns in sperm donation. This is really important when we're thinking about male infertility in African-American communities. There's a ton of medical mistrust, and I think that's really important for us to think about when we think about why these disparities exist. So these are widespread attitudes stem from many unethical yet sanctioned medical experiments that were performed on African-Americans in the last several centuries. Some of the most notable ones, the Tuskegee syphilis study, for anyone who's done any research, you definitely have to, learn about this before you can even do any clinical research here. Most people know about Henrietta Lacks and the HeLa cells and how that has contributed tremendously to research, but also kind of unsanctioned medical care. And then finally, federally funded sterilization programs, which were present not too long ago, stemming from the early 1900s up until even the late 1990s, so really not that long ago. In December 2015, the US Senate actually passed the Eugenics Compensation Act to help survivors of forced sterilization. So this is really an important context to think about when we think about why patients may not seek care, particularly those in underserved populations. This is really contributing to why there's quite a bit of mistrust and perhaps why people are not seeking care when male factor infertility may be at play, just because a lot of things pertaining to fertility has really been taken advantage of, quite frankly, through the years. There continues to be major mistrust and fear of the healthcare system by African Americans, and unfortunately, this has really resurfaced during the pandemic. And although bioethical research has advanced, donation and utilization of sperm can still be seen as experimental, with tons of skepticism about its ultimate use and source. And so reproductive health and rights overall just continue to be a major issue. And then religious considerations, I briefly mentioned this before, but this is also a major driver when we think about attitudes regarding infertility treatment and can really influence how people seek out subsequent care. Varying degrees of support and allowances are there for male infertility stemming from Catholicism, Islam, and Judaism. And religion can also really dictate support for married and unmarried couples and those who identify as LGBTQ. So in conclusion, male infertility is a common disease with unknown prevalence in communities around the world due to cultural and religious reasons, as well as reporting limitations. There are several barriers that I spoke about, and hopefully that'll help give you context as we think about why we're facing this issue and what we want to do about it. And we really need to continue understanding the complex relationships that persons of color and other minority groups have with the healthcare system that may inhibit engagement for fertility care. Thank you so much.
Thank you so much, Denise. Sorry, I was having a little trouble unmuting myself. I am going to be the second panelist today, and I'm talking about how we can improve access to care through better education. Here are my disclosures. I'm an advisory board member for Posterity Health. And the goals of my talk are really twofold. The first goal is to discuss how we can better educate our physicians with respect to male infertility and andrology. And I'm coming at this not only from the perspective of a reproductive urologist, but also the perspective of a residency program director, recognizing all of the teaching that we have to pack into just a few valuable years of residency training. This study was done by Dr. Niederberger and his colleagues, and it's really an interesting take on what the exposure to andrology and male infertility looks like from the perspective of a trainee. This group of authors did a representative cross-sectional survey of current urology trainees in the United States and in Europe. And the sample is interesting because, you know, both in the US and in Europe, we have obviously the AUA and the EAU, and both have subspecialty organizations that are focused on andrology and male infertility. A total of 171 residents completed these surveys. 59% of them were from the US, about 41% were European, and response rates overall was about 35% on average, which is, you know, on par with the majority of these surveys. You can see in this table on the right that the duration of exposure to male infertility was really variable across programs. And interestingly, in the United States, exposure clustered at either the low end or the high end of the spectrum. So either, you know, 1 month or over 6 months. And this is more than likely reflective of whether or not there is a dedicated reproductive urologist present as part of the academic faculty in that particular training program. Seems to have flipped through. Yes. So the same paper, this is a second, set of results from the same analysis. And in this particular figure, we see what the responses of the residents were broken down between the US cohort and the European cohort. And the first question here is, you know, do you even think that exposure to male infertility and andrology training is important? And overwhelmingly, the response is yes. If you look at the second question, you know, there are fewer residents who say that they had appropriate in-service discussion or appropriate training during their internship and residency program within the subspecialty. And then you look at the third question about whether or not they feel comfortable evaluating the infertile male. And now the numbers become really, really small, with only about 50% of residents in the US saying that they feel comfortable, and only about a third of those in Europe saying that they feel comfortable. There were some additional questions here included about the medical school experience, which, you know, is even harder to include this discussion there, although we'll talk a little bit later in this presentation about why that may be important. Skip a few more questions down to this question that asks respondents whether they would use testosterone to treat hypogonadism in men desiring fertility. And this, of course, is a parallel question, right? And it reminds us of Dr. Brannigan's paper published almost a decade ago now, which was a survey of the AUA membership asking this very same question: would you prescribe testosterone to a man who's seeking fertility care? And here too, there are, you know, a substantial number of residents that say that yes, they would, indicating again this disconnect between, male infertility knowledge and clinical practice. If you asked this group of residents whether or not they would feel comfortable going to their own institution for male infertility care, very interesting responses there, with only about 22% of those in the United States saying that they would feel comfortable going to their own institution, and about 42% of those in Europe. So all in all, the takeaway, you know, from this paper is that we can definitely do better. Our trainees certainly have an interest in this. They certainly see value in this, and we have so much room for improvement. This next study looks at the trends in terms of subspecialty training in andrology. So Dr. Bach and his colleagues assessed changes in urologists' practice patterns in the United States with respect to delivery of care for male factor infertility. They used data from the American Board of Urology case logs, and they stratified this across two different time periods, the early period and the recent period mentioned here. And they note an increase in the proportion of urologists that are identifying as andrologists during these two time periods. So more and more are entering fellowship training in general and entering fellowship training from the perspective of andrology specifically. This is the same paper again, a different set of data, different set of results. And here the authors are actually breaking down the proportion of cases performed for male factor infertility by those in the early group versus the recent group. And this is looking only at those who respondents who identified as having had subspecialty training in andrology. And you can see that in this cohort of fellowship trained individuals, there are more and more that are practicing within these male infertility specific cases. And this is a trend that's seen not just in andrology fellowships, but really fellowships within all of urology, where there is more and more subspecialty certification and specialization. And I mention that because it's important to think of this discussion in terms of challenges that currently exist and opportunities that are available for us in the future. One of the biggest challenges currently is that we do have this limited number of male reproductive urologists, not only in the community, but at academic medical centers. And this impacts how we train the next generation of physicians. And the second big issue is that andrology and male infertility fellowships, whether they be in the United States or in Europe, these are not generally ACGME accredited or certified by any other subspecialty society or professional society in the way that SEO fellowships are certified. This means that these fellowships are not necessarily standardized and perhaps not well recognized when providers do go out into practice. And it may help us to, have some standardization in these fellowship training programs to make sure that we are meeting some minimum criteria for education, not only in the outpatient clinic, but also in our ORs. As I mentioned, there are a number of opportunities as well, and I see these as positives. So certainly there is this recognition that training in andrology, male infertility is very important. The AUA core curriculum has certainly put emphasis on this and includes detailed coverage of andrology now on their website, which is available for all trainees. There are a growing number of fellowship trained subspecialists in andrology and male infertility. And there's also a growing number of fellowship training programs, so small but growing. And I think with time, this will have an impact on our subspecialty for sure. Exposure to andrology and male infertility is also recognized as an essential component of REI fellowship training. And for those of us who collaborate closely with our REI colleagues that are involved in training REI fellows as well, we can make an impact on their overall education and on their management of patients in the future as well. Who is providing infertility care in the United States currently? So Fantas and all looked at the data from the National Ambulatory Medical Care Survey, and this was done over a 10-year period as shown here. And there were about 8.7 billion healthcare encounters that happened in this time period. 3.2 million of them were specific to a diagnosis of male factor infertility. And you can see there's an almost equal split between urologists and primary care physicians seeing patients for this diagnosis. There were also several gynecologists and then a group of other physicians, possibly some combination of endocrinologists and others seeing these patients. So it is not just the urologist. There are many medical subspecialties where these patients may present for their initial diagnosis and care. And related to that is the fact that, infertility and general general health conditions do go hand in hand with quite a bit of frequency. And you can see on this graph on the right that medical comorbidities were really common in this patient population, ranging from metabolic diseases such as diabetes to social habits such as tobacco use, as well as health risk, sort of high risk diagnoses such as cancer. Now on to the second part of my talk, moving from trainee education to patient education. So this was a paper that was published by Dr. McLaughlin and his colleagues, and it's actually a review of what is present in the literature related to men's knowledge regarding their own fertility. And these authors included about 43 studies in this review paper, spanning, again, a time period of about 10 years. And they found that men aspire to parenthood just as much as women do. But in contrast to their female counterparts, men have very limited knowledge about the factors that influence their fertility, and they often will overestimate the chance of spontaneous and assisted conception. This is particularly important in light of the fact that more and more couples are delaying, childbearing until a time when they are financially secure and able to support their family. And there is certainly an underestimate regarding the decline of fertility in both men and women with age. There are certainly some specific male partner needs, and this has been shown in our own research as well. We performed a qualitative analysis and a focus group study of men seeking fertility care. And the goal here was to really look at the experience and needs of male partners in particular, who are being faced with either male factor or female factor infertility. And we found that male partners of infertile couples really experience significant emotional and psychological distress. They often do not have a lot of resources to turn to learn about what is going on with them. They have unmet needs, which include tailored educational resources and support services. And in particular, in our focus group study, patients identified the need to better integrate reproductive care for themselves and their female partners, to have better physician empathy for diagnosis of male factor infertility, and also physician optimism in terms of reproductive potential and improvement in reproductive potential with respect to medical and surgical treatments. And this, I think, highlights, an important area when we talk about patient education. It's not simply enough to come up with educational materials or pamphlets or videos for our patients. In fact, it's really important for us to actually figure out what our patients' unmet needs are, where they are in terms of their educational level, and then how we approach them and meet them there so that they can really become active participants in their care. One of our residents had looked at what patient-directed information is currently available online, and the study is already a few years old, but he had performed this detailed survey of infertility treatment center websites, since so many of our patients are looking online for health-related information, and he did a systematic data abstraction evaluating exactly what was related to male factor infertility that was mentioned on these websites in terms of diagnosis, medical treatment, and surgical treatment. And he found, shockingly, that information pertaining to male factor infertility was completely lacking in over 20% of websites, so 1/5 of these websites. And urologic referral was only mentioned, in less than a quarter of cases, which was really, really shocking. The last thing was that the technical content of most of these websites was written at a very high reading level, a 12th grade reading level. And to put this in context, the AMA recommends that the majority of our medical information should really be geared towards a 6th grade reading level. So here we are thinking that we are putting out this information for our patients to review, and the majority of them are not even really comprehending what it is that we are trying to relay to them. This was another interesting study performed by Dr. Halpern's group at Northwestern, and they actually looked at search results for what happens when patients go to Google and enter, a search looking for a male factor infertility specialist. The majority of the hits that come up are actually not urologists, they're gynecologists, and even the urologists that do come up in these searches, the minority of them are really fellowship trained in andrology or have subspecialty interest in male factor infertility. So patients really have to be very dedicated and determined to find a specialist to undergo their diagnosis and evaluation. And we really do need to do our part to make it easier for our patients to be able to get to us in terms of addressing their reproductive health needs. In summary, the need to improve trainee and patient education is essential. And by improving education in both of these arenas, we can really help reduce many of these barriers that are present in access to care. Certainly a better appreciation of health literacy and the needs of our patients is needed to implement and disseminate the resources that we already have, but to also develop and then disseminate new resources tailored for our male fertility patients. A collaborative approach, whether it's with our colleagues in medicine, within urology as well as outside of urology, REIs, primary care physicians, endocrinologists, as well as a collaborative approach with our patients and their partners is key in order to make this happen. That concludes my part, and I'm going to turn it over to Dr. Bakare.
Thank you very much. Thank you so much for having me on this panel. I feel very honored to be a part of this wonderful group of people. And I hope to be able to add some good input to this wonderful conversation going on already. So those are my disclosures. So I think in order to find solutions to anything, we must first acknowledge that there's a problem. And my colleagues have been able to lay out the case that there is a problem with access to fertility care for some men. And I hope that I can offer some applicable and straightforward solutions for us in this webinar today. So my objective is to review some of the roadblocks, explore ways that we can improve access to care, and then discuss some future suggestions and opportunities to improve access for our patients. So I want to start with this statement that states that that declared fertility care as a basic human right. In 2009, the World Health Organization also defined fertility as a disease, which is supposed to help to dispel that fertility care is elective. As mentioned before, approximately 15% of couples are unable to conceive after a year of unprotected intercourse, and male factor can be responsible for upwards of half of those cases. Okay, wait. Okay, there we go. So despite those estimates, the true prevalence is unknown, and it's not clearly defined due to some of the factors that were mentioned below, differences in the sources of data, lack of adequate reporting for religious reasons or for whatever other reasons of lack of acknowledgement of the disease due to it being the fault of the woman typically. The overall goal in the evaluation of a man is to identify the conditions that may potentially be causing infertility, identify conditions that may affect the management of or the health of the patient and their offspring. So why is it important? Why is it important that we make this so accessible to all patients? Improved care and early diagnosis of conditions that are related to infertility is one of the things that we can achieve with this. Things like diseases like prostate cancer, testicular cancer that have been found to be associated with infertility are things that we can diagnose earlier. And in African-American men, prostate diseases like prostate cancer tend to be more aggressive. And so in order to catch those patients earlier, it's important that we're able to have access for those patients. It improves our healthcare cost. In 2009, the Joint Center of Economic and Political Studies found that there was an excess of $229 billion that was spent due to health inequalities from cares such as ICU stays or cares from advanced diseases. In addition, improving access can help reduce some unnecessary procedures. For example, it can encourage single embryo transfer, which can hopefully improve normal birth weight infants, which can improve benefit the patient, benefit their child, and the overall healthcare system costs. Also, improving intervention, improving cost of intervention to men. For example, doing a varicocelectomy on a patient with oligospermia may potentially normalize their semen analysis and enable this couple to conceive naturally. Improving fertility stressors for our patients, which is one of the ultimate goals that we try to achieve as fertility specialists, would be another important reason to care about access. So this wonderful study done in 2016 by Dr. Mehta beautifully outlined the different barriers that we have in access to reproductive care. There's epidemiologic factors, geographic factors, knowledge-based, which I think, which Dr. Mehta just touched base on, financial, socioeconomic issues, and government and health policies, and we'll dive into those topics a little bit. So I would argue that to solve epidemiologic, geographic, knowledge, and socioeconomic barriers, we have to do a good analysis as who we are as an organization and how many of us they are, how diverse are we, what are we teaching our residents, are we doing enough to teach our residents, and are we making sure that we're continuing to recruit residents and fellows into this wonderful specialty of ours. You know, there's credit to be given to representation. And we know based on other studies and reports that patients respond to physicians that look like them. Patients feel more heard by physicians that look like them. And, you know, I look at the AUA census, and between 2019 and 2020, we have very little change in the diverse picture of our organization. Diving a little bit deeper, like was previously mentioned, we have about 3.4% of urologists that are male infertility specialists. I don't think it's that much to assume that if there are 3.4% of urologists being male infertility specialists and only 2% of urologists being African-American, the percent of male fertility specialists that are African-American is pretty low. You know, I've been very fortunate to have a practice where, looking at the data of my patients, I have a practice that is very representative of the community that I serve. I think one of the things that I personally enjoy doing that I think has contributed to that success is outreach to minority physicians in town. So outreach to minority OBGYNs, to minority family medicine doctors, the people that are kind of the gatekeepers, quote unquote, and seeing those patients first to ensure that those patients get to me to be able to get the care that they need. You know, I do community events where I have conversations in churches or other community events where I'm invited to speak as a fertility specialist or as a urologist, and I'm able to kind of discuss fertility and male reproduction during those sessions as well. So the other point that I was going to make here is, in order for us, when we start seeing these patients, it is very important for us to recognize as physicians that we're humans too. We all have biases, and we have to be able to recognize them and course correct when we do have them. It's important that we don't interpret patient symptoms the wrong way, predict our patient's behavior. For example, making assumptions that about whether people can afford IVF or whether they can, or whatnot. I think it's important that we try to treat all patients the same, because when those patients are referred to us, they go back and tell the referring physicians how they were treated, and that can either continue to build that diversity in your practice or frankly halt it. So I think that it's very important for us to understand that as physicians, we are biases too, and there's nothing wrong with that. We just need to understand it and course correct when we notice that we have those biases. So while we're working to achieve diversity in our group, telemedicine is another way of reaching out to patients that may not have the geographical access to us. I mentioned telemedicine, but I also would love to mention here there are many patients that also do not have access to things like technology, like internet, and so it's important that we're flexible with this telemedicine. That can come in form of a telephone visit or a video visit. And this can address some of the issues with outreach to patients that are underserved, and even some patients that may not have access to technologies like the internet. So moving on to the financial and the government health policy part of this. Insurance companies are notorious for not having adequate fertility care. 19 states in the United States have a mandate to cover, and I say mandate in quotations because it's sort of a mandate. Texas and California mandate insurance companies to offer insurance, to offer fertility care, but they don't necessarily mandate those companies to actually cover it. For states whose employers basically are self-insured and provide that insurance to their employees, they are completely exempt from that rule. And so even in those 19 states, if your employer happens to be self-insured, you don't get access to fertility care if they want to be exempt and if they don't want to have to provide that. Several of those mandates also exclude single men. They exclude same-sex individuals by assuming in the wording of the document that the patient is in a heterosexual relationship. The mandate in Texas includes the criteria that the patient's eggs must be fertilized by her spouse's sperm. There are other mandates that acknowledge that that basically put women in heterosexual relationships and women in same-sex relationships in a bind, and require that they go through multiple cycles of IUI before they would cover IVF. I mean, there are mandates that require that women go through about 12 cycles of IUI before they would let them go through IVF. This is obviously ridiculous and a harm to the patient, not only physically, but emotionally. And these are things that we as physicians need to be aware of and be able to fight for when legislating for our patients. Patients requiring gonadotoxic treatments. Most of them are not included in many fertility mandates. 10 states currently have mandate coverage for oncologic fertility preservation. And again, many of those, even though they call it a mandate, is more providing the option and insurance for patients, not necessarily forcing the insurance companies to actually provide the care and the coverage. So I'm going to summarize by saying with this, and I think the ideal scenario in the future is to have universal federal fertility coverage, regardless of partner status, regardless of sexual orientation, regardless of who you are. While this is something that we can aim for in the future, we must continue to champion legislation that gets us closer to this. We as physicians must understand the local and state legislations that guide the care that we provide. I've been fortunate to be on a group here in DFW, in the Dallas-Fort Worth area, that submitted legislatures to the House here, and Unfortunately, they didn't get to it to be able to vote on it, but we're going to keep pushing. I think it's important for us to be involved in these things because these things affect our patients' lives every day. And lastly, we must continue to improve and diversify our specialty. So I'm going to conclude with saying, listen, we're all human beings. We have biases, recognize them. When those patients come to you, in order to make sure your practice continues to stay diverse, you have to recognize that there are times that we input our biases on patients and we have to be able to check that and course correct. We should continue to strive to eliminate the barriers like we talked about by legislating for our patients every chance we get. Outreach to physicians that are kind of the first line to this patients would be very important in building that diversity and continuing that diversity in your practice. And of course, diversifying our specialty will be something that would be phenomenal to achieve. Thank you very much.
Great.
And I think I'll pass it on to Dr. Dupree.
Great. Thanks so much, Dr. Bakare. And like everyone else, I really appreciate the opportunity to chat here this evening. And so we'll just go back to the first slide, if we could, please. Great. Sorry, the next slide will give me disclosures. If I could take control of the slides, that would be very helpful. Perfect. Great. So these are my disclosures. And for an agenda, here's what we're going to talk about. We're going to talk about infertility as a disease. And then we're really going to go kind of much more deeply about insurance coverage. And really, this talk nicely dovetails with many of those that you heard, including what Dr. Bakare was just talking about. And we're going to get into some of the data about exactly how insurance in particular can matter to our patients and how insurance changes can be used as a lever for us to create positive change. You've heard many folks mention that infertility is a disease. I thought it would be useful to list the specific language that's used by the World Health Organization, endorsed by the AMA, and the language used by the ASRM to clarify why we believe infertility is a disease. And this is an audience that I know probably does not need any convincing for this, but I think it's useful as we talk about infertility outside of our sort of ASRM and Resolve communities, that we clarify that no one chooses to have infertility. This is a deviation from the normal function of the reproductive system that folks don't elect to have. People don't want to have infertility. And what we know from some national data, this is national data that Angela Kelly worked on, about 12.5% of all women report infertility. And then when you look though at the women that are reporting infertility and you break it down by their household income, you can see that infertility doesn't discriminate, that there's really no statistical difference in the percentage of women in these 4 different income brackets in terms of their report of infertility. When you look at self-reported race and ethnicity among women as well in this survey, there is no significant difference in the percentage of women in these 4 different racial ethnic groups that report having infertility. So infertility doesn't discriminate. Infertility doesn't really care what your income is. It doesn't really care what your race ethnicity is. And we need to keep that in mind when we think about our patients. Everyone has infertility in really kind of strikingly equal percentages. So infertility care, though, is really expensive. And folks have kind of touched on this already, but this is some great data that came out of Jim Smith and the group he works with at UCSF. There was a survey of over 100 men that are receiving infertility care who really spent a shocking amount, almost a fifth of their income annually was spent on infertility expenses when they were in the midst of their treatments. And almost half of those men had their treatment options limited by the cost of those treatments. Not surprisingly, then, the corollary is that college-educated and higher income couples were those that had the most access. And I think we can understand that that's not just, right? That's just not the justice that we want in our system. But insurance is a really powerful mechanism to help mitigate some of those disparities. So this is data from the Kaiser Family Foundation. This is not specifically about infertility insurance, but it looks at whether or not people are postponing their care or went without care because of costs by their insurance type. And what I think you can see clearly is in the lightest blue bars, which are those people with employer-sponsored or private insurance, had much lower rates of postponing care or going without care due to cost. Those without insurance were really avoiding care or postponing their care in really kind of frighteningly high rates. So unfortunately, though, few insurance plans cover infertility. So this is some data that Resolve sponsored. It's over about 15 years old now, although there are some very recent updates. The numbers have improved a little bit, but not dramatically so. That only about a third of employers are covering drug therapy, and only about a fifth are covering IVF, which is, even for a male infertility audience, is a really important treatment that we need to be able to offer to our men. So people just don't have insurance coverage for the best and most advanced therapies for infertility care. But we can learn about what happens when a company does choose to cover infertility care. So this is the story of University of Michigan. So in University of Michigan back in 2014, announced that they were going to start covering IVF for their employees. They implemented this in 2015, and the specifics of the coverage, and they're a self-insured plan, they decided that for the patients that were less than 42 years old, they would be covered in this, that there is some patient cost sharing. So there would be a co-insurance as well as a lifetime maximum with an estimate that this would cover 2 to 3 cycles. And importantly, there were transfer restrictions, and these lined up with sort of the best practice statements from ASRM about single and double embryo transfers were really required by age. We had this really unique opportunity then to understand what happens in an employee population when a company goes from not covering it, presumably therefore there are many barriers, to starting to cover it, where presumably some of those barriers are removed. So here's what we saw. So not too surprisingly, we saw a pretty dramatic increase in the use of IVF after the policy was put in place. So to orient you here, 2012, 13, and 14 are the 3 years before the IVF policy went into place. 2015 and 16 are the 2 years after. And the y-axis here is the IVF rate per 10,000 women. So this is normalized for the employee population size. So we had about a 3-fold increase. But what I think is even more cool is that when we looked at this by salary level, so again, here to orient you along the x-axis are women in the low salary, or the middle salary, and the high salary groups here at the university. And we were able to look at the rates of the IVF use before in yellow or after in blue, this IVF policy was put into place. And what we really saw is that IVF use went up in all of these salary groups, but it went up a ton in the low salary group. And so we really interpreted this to mean that insurance in an employer-sponsored situation can dramatically improve access to IVF, especially among low salary employees. And we also kind of displayed this a different way, and I find this maybe an even more powerful way to describe, at least from an equity standpoint, the implications of this. So this is the U of M employee population. So using kind of the definitions that our benefits office describes, half of the U of M employee population is high salary, a quarter middle salary, and a quarter low salary. So this is just kind of the employee population at large. Before IVF was a sponsored benefit, this is the breakdown of who was using IVF. So among all those that were using IVF at U of M, about 2/3 were actually high salary, and only 6% were in the low salary group. So these two distributions look very different, right? Clearly, it's those in the low salary group that were not using IVF in proportion to how common folks were in that employee salary group at the university. Now, after the policy was put into effect, this is the bar all the way on the right, you can see that the distribution of these 3 colored groups almost exactly mirrors the distribution of the employee population as a whole. So we interpreted this to say that when IVF is a covered benefit, the breakdown of who's using IVF starts to look a lot like the breakdown at the university. So we took this as kind of a positive equity sign. So what can you do, right? And so others have talked about this already. Number one, I'd say talk to your employer. Resolve has some outstanding resources in their coverage at work policies that I'd really encourage you to look at and use. Reach out to me. I'm happy to help and talk to you about sort of at least what the story at U of M, and if that story helps at your employer, I'd be happy to talk with you. As Dr. Bakare mentioned, advocate in your state. And I think it's really important to support both AUA and ASRM Resolve advocacy efforts. And I've listed the upcoming advocacy efforts for both of those organizations here on the slide. Dr. Bakare mentioned both kind of state and federal legislation about this, and here are some examples. Dr. Hendren told me actually before we got started that Washington State should be the newest state that we add to the top bullet here. And so I'd really encourage you to use your voice and get involved. So in summary, I hope that you can kind of leave this session understanding and believing that infertility does not discriminate by socioeconomic status, that insurance coverage can be a really important lever that we can pull to improve access to care, acknowledging that it's just one of many levers that addresses one of many barriers, and that really you can get involved by advocating for better insurance coverage, both locally and federally. And my hope is that through both kind of thinking about these topics and the topics from all of our other outstanding panels, that we can move our system from one that's in the upper left here of one of true inequality that happens right now to one of justice, which is really depicted there in the lower right. So I really thank you for your attention today, and this now will begin our question and answer session. Thank you.
Well, I'd like to thank all of our panelists. I really appreciate the terrific talks that all of you have given during this session. And so I'd like to start, since Jim, you just gave this great talk. We've talked a lot about infertility as disease during this session. And one of the things that often comes up is this idea that, well, why should we provide this care? Building families is an elective process. So I'm curious to hear, Jim, now from your perspective at University of Michigan, what do you think was the most compelling factors or set of factors that led to University of Michigan offering this important benefit? And what kind of tips would you give to the rest of the country as they think about that?
Yeah, it's a great question, Jim. Thank you. And I want to say at the outset, I was actually not present at the university when the advocacy happened, so I can take no credit whatsoever for kind of the arguments that were made. And there's some great stories online you can read about the folks that were involved. So I want to be very clear and give thanks to those that were involved. What I have been told is that really it was about justice and equity, that was the line of discussion that really resonated the most. It was actually a set of graduate students at the university that started first having these conversations, saying that graduate students are really integral members of the university community, yet their salaries are really pretty low. And they're a population that has a strong interest in building their families. And so they felt sort of that there were structural barriers. And so they really talked about how there was really unequal access. And that was the argument that resonated the most. And as I've talked with other employers that have very recently made these decisions, honestly, that's the most common argument that I hear that is kind of resonating or getting hold. And of course, there are questions about cost. And of course, there's questions about how it's going to be structured. But that's something that is often a pretty powerful argument, especially I think as we've rightfully been paying a lot more attention to equity and justice now than we have over the past decades, when it was unfortunately overlooked to a large degree. And so the other thing I would say is understand your organization, understand the values that your organization talks about publicly, and use some of those values to frame your conversations about insurance coverage and access to infertility care, because that's really what your organization is caring about, is what they're talking about publicly.
Well, thank you, Jim. I think those are really such important tips. Denise, I wondered, from your perspective, a couple of things you really resonate with me and questions that I really wondered about. You mentioned the importance of stigma in the African American community in terms of some of the really terrible things medical community has done before. I'd really love to hear your thoughts about ways in which we could break down some of these stigmas, improve trust within many of the communities of color in the groups that we serve around the country.
Yeah, and great question, Dr. Smith. And I think, Tolu kind of said a statement that resonated with me. It's like we can't solve a problem until we admit that it's actually present. So I think people really appreciate if you just, acknowledge, even like a statement with, I know that there may be, some concerns or some hesitations around this, but I'm here to help. I think the way you can really connect with patients and just show that you have some humanity around acknowledging, that past, I do think it goes a long way. And I'll say, myself as an African-American physician, even when patients come to me, I get that too, where it's just like, I may not necessarily trust you just because, you're African-American because of these issues, but I do try to just acknowledge, I get it. I know that there has been some awful things in the past, but I do think we have come a long way to change a lot of those things. And if you entrust me with your care, I think we can really make some progress. And I think that actually goes over well with people. And, it may take maybe a visit or two before people, really feel like they can, connect more with you. But I do find that it's more the lack of acknowledgement and that really perpetuates people's concerns and, fears around kind of trusting us.
I really appreciate that. Tolu, I was impressed too with the work that you did and continue to do in terms of you're really being very proactive in terms of getting out into the community and finding ways to form really deep connections with the community. I was wondering if you wouldn't mind, again, just sharing some more tips with our audience about things that you found have worked really well to help build those kinds of community networks.
I've been very fortunate to connect with some pretty amazing minority physicians in town, and I think it's been tremendous for me to maintain those relationships because when you treat those patients and you care for them in the right way, they go back and they tell them that this doctor did this and was good and da 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 da. And that enhances that relationship. And so they continue to refer you patients. And I guarantee you, even though some of them may have seen me initially because of what I look like and because they feel more comfortable talking to me, there's something to say about the way you make somebody feel that when they walk away from you, they remember that regardless of who you are or what you look like. And so, I've had patients say to me, they just made me feel like they didn't care about me as a human being. And, that it's sad that we have to say that in our field because we are physicians and this should be inherent to what we do. But the reality is, I as of last week, I still had a patient tell me that he felt dismissed by a physician, and he almost brought me to tears because he just continued to talk about how emotional it was for him to see a physician that had looked like him, not physically, obviously, but had the same skin that looked like him, that made him feel like he was safe. And when he said that, I literally almost cried on the telehealth visit because it was just such a validation of everything that I truly believe that our patients look for this. I have patients seek me for this. And so it's so important that we improve this. I think some of the other things that I've done is whenever I get an invite to speak at a local church, I do it. It may seem small and it may seem like, listen, I have a bajillion other things to do, but that is the way I can reach this patients that for religious reasons believe that, oh, God would take care of it, so I don't need to see a fertility specialist, right? But then in conversing with me, they ask me questions, and every little bit helps. If I can go to 5 churches in my community, then those are potentially 10, 20 men. And then those 10, 20 men tell their friends. I've had several patients that showed up in my clinic saying, oh, my friend told me about you, and so I'm here. And so we don't recognize the ripple effects of those small things we do and how large they can become for us in diversifying our practice. So I think it's so important to take advantage to, even when it seems like minute and small, to take advantage of those moments we can actually reach those patients that may have doubts unless somebody like you and I, go there and actually have that conversation with them.
Thank you. I am struck as I listen to each of you speak. I'm really struck by how we're probably really just treating the tip of the iceberg so far as the patients who are out there. I think there's dramatically really more demand for the services, yet there's limited number of people and trained physicians who are able to offer these services. And so, Akanksha, when you gave your talk, I thought one of the slides that was really relevant to this was the percentage of primary care physicians who are treating men for fertility. And I didn't hear you mention much about the educational training. You talked about the role of the AUA core curriculum and how we're at least moving toward better knowledge-based training for urologists and fellowship trained people, but it seems there's just not going to be enough of us. And so increasing the supply, that's a big challenge of reproductive urologists. But I'm curious if you wouldn't mind just talking a little bit about ways to, there are a lot of primary care docs and internists. Are there ways that this could help increase access to reproductive care?
Yeah, absolutely. I think, the primary care physician is still the first stop for many of our patients when they are coming in with concerns about their reproductive health and sexual health. Sometimes they are referred through that portal as well. And for primary care physicians to have some working knowledge of what goes into a fertility evaluation, at least what the red flags should be for that patient, when that patient should be referred and to whom. I think that's critical to sort of moving the needle on this whole issue in terms of access to care. One of the ways that we have implemented this for our group at Emory is to really do a lot of outreach to our primary care colleagues, whether that be education in terms of prevalence of male infertility, education in terms of the fact that so much of male factor infertility is actually addressable and treatable. We can do patient education, we can do medication, we can do surgery to address so many of the concerns that our patients are coming in with. I think that is a really kind of valuable bridge to build with our primary care colleagues. And in the same ways that Dr. Bakare was talking about, doing outreach in her community, I think building those bridges with our colleagues in other subspecialties opens the door in terms of new referrals, more appropriate referrals, more timely referrals. And a lot of times the primary care physicians will actually start the workup for me. So they will go ahead and order a semen analysis, and they will go ahead and order some hormone labs before sending the patient over to me, which really saves a lot of time for the patients and just makes that first visit so much more meaningful for them. When I started doing some of these outreach webinars and meetings with our primary care physicians, I was struck by the fact that many of them didn't even think that they could order a semen analysis, or that they would be allowed to order a semen analysis. I know that seems silly, but for somebody who doesn't order this test frequently, there was this big sort of unknown box of how do I even go about doing this. So even just the simple act of talking them through, how do you order one? Where do you tell your patients to go? Now there are, at-home tests that many patients can do, and what do they do with those results? That in and of itself has been a huge help.
Yeah, no, I think those are really important points, and I'm really grateful to the American Society of Reproductive Medicine, for allowing us to really begin this discussion. I hope it's really, one of many. I know we're over time. I've got a couple of questions. One that's probably most really for Jim. So this is from Dr. Rahim over in Chicago, and he asks us, great session, thank you. The University of Michigan model for infertility coverage is encouraging, and I hope to see it across the United States in the future. Do you have data on the private versus academic coverage that impacts male infertility treatment and outcomes?
So excellent question, and unfortunately we don't. Right, so we don't really know kind of how different packages will impact the access or the outcomes themselves. It's a really important question, and hopefully we will learn more about that soon.
Yeah, the second question we have from Dr. Barrios is one it's tricky. I mean, it really speaks broadly based, lacking access to reproductive specialists, but can we as a group speak to the role of referral or lack thereof among urologists, especially at places where there's no dedicated andrologist or male fertility specialists? I'd really love to hear from anybody's perspective. All of us by definition are places where there is a reproductive urologist. I'd love to hear people's thoughts on that.
I'll speak briefly on this only because I'm now at an institution where someone dedicated in what I do hasn't been present for about a decade. So I'm really kind of bringing back, this service line at Loyola. But I think at least within the Chicagoland area, there's great people, here in Chicago who are also, leaders in the field who I think, despite their being in absence for a while, I think patients did have the ability to, get referred out. I do think that most urologists, feel comfortable with kind of an initial, semen analysis. And I think the more that people are educated on just, where colleagues like ourselves lie, I do think they're pretty open about the, referrals. So I think this continues to be an area for us where we can continue to improve. And now being in such a supportive group now, I think the moment anyone, it's like anything infertility, they're starting, your way. And so hopefully everyone's groups are like that. But I think that patients are also becoming, I think, a little bit more in tune now with social media and, different things that they can, look it up. I think people are at least finding even social media presences where they can get some initial questions answered, before they go ahead and just, find a provider that specializes in this.
Yeah, I think it's a really tricky problem. I mean, so through our societies, through both SMRU, Society of Male Reproductive Urology at ASRM, and then SSMR, our AUA society, we would like to have a list of reproductive urologists, but those really are not as robust as they should be. But I think that's an aspirational goal for us as a society, is to make it easier to find us across the country. Well, again, with that, I know we're over time, but I'd really like to thank ASRM and the special interest groups who've allowed us to have this discussion today. And thank you to all of you really for spending part of your afternoon with us. So again, thank you all very much for a terrific session.
Thank you. Great session. Great panel.
Thank you.
Thank you very much.
Thank you, everyone. Thank you to our moderator, to the organizers, to the panelists. Thank you for extending beyond the hour. I hope everybody has a good night. This session was recorded and will be available on the ASRM website. This concludes the webinar.
All right.